this series, we'll speak with scientists from the Dangoor Center for Personalized Medicine to gain an up-close understanding of what happens in their research laboratories, which developments are expected to reach the market, and how medicine will look in the coming years. This time we're hosting Professor Noa Vilchinsky. Professor Noa Vilchinsky is from the Department of Psychology and the Dangoor Center for Personalized Medicine. She specializes in a very unique field on the psychology of heart diseases and rehabilitative psychology, and she's the director of the Psycho-Cardiology Research Lab. Noa earned her doctorate from Bar-Ilan University and completed her postdoctoral fellowship in the cardiology department at Mayo Medical Center. In 2018, she received a prestigious European Union grant in the field of caregivers. Noa, thank you for joining us.
Thank you for hosting me.
From what I understand, the physiology, the actual event of the cardiac event is just the beginning of a whole process, that there's so much trauma associated with it, that there's a lot that follows afterward that impacts the families, the people. Tell us a little bit about this field. I was unaware.
Absolutely. Now, just imagine a person walking down the street. He was told that he's totally fine. He is in the beginning of his 60s, early 60s, and then a cardiac event hits, what we call myocardial infarction, but what we all know as
heart attack.
In a minute, in a second, he moves from being totally healthy to the experience of near death. Mm-hmm. And when he realized that, in hindsight, when he wakes up at the hospital, it's so terrifying to know that you were that close to living this existence. So person usually react with major depression, much anxiety, and even post-traumatic stress disorder. And not only them, but also their family members, and specifically their spouses, react even worse, because many times the person who had a cardiac event doesn't even remember.
Wow.
He lost consciousness. Right. But the person who was in the scene, observing, dialing 911 or our emergency services, watching him plug to all these systems, and even watching resuscitation event.
If they flatline, for example, right?
So the person, the partner, the caregiver can react in much trauma later on, depression, anxiety, and later on taking care of the patient with much burden, because taking care of a cardiac patient takes a toll on the patient caregiver, which many times, or almost all the times, is the partner of this patient.
This is so interesting. Honestly, this is one of those fields I never thought about. You think they go into the hospital with a heart attack, they get fixed, hopefully, right?
Exactly.
To use the layman's term. They go out, some people are told they have to be careful, they have to fix their diet, their exercise, but it's all very physical and physiological. But what you're saying makes perfect sense. It's terrifying.
It's terrifying. Not only that, we know that cardiovascular diseases are the #1 killers in Western countries. It's going to be like that also in non-Westernized countries. It's going there. But, it's common knowledge. So people know about the danger of dying from a heart attack. They see it on movies, and they understand that now they are in risk for getting another cardiac event. So they cannot take their heart out of their chest and say, well, now I'm free of this. No, they walk around with a
ticking time bomb almost.
Exactly. This is the exact feeling. So it's really terrifying. And we know the number. We are talking about 30% of all those who went through a heart attack showing depression symptoms. 30%. That's huge.
That's huge. And you also mentioned their caregivers.
And the caregivers as well. Not only that, we see that in many studies that the caregivers present higher odds of mental illnesses or symptoms. I wouldn't take it as far as mental illnesses, but definitely symptoms of depression and anxiety and even PTSD, which are double than those of the patient himself.
Well, that makes sense. As you mentioned, sometimes they're not even aware of what's happening, but it's scarier to watch it happen to somebody you love than to actually experience it unless they have, you know.
Exactly. Not even, you don't have to be in the scene even, just hearing about it later on makes you think about being left alone,
right?
About the possibility that it can happen again, and then you become very, very annoyed with everything the patient does that doesn't fulfill the actual behaviors that he should do in order to avoid another event.
I can imagine wanting to kill my partner if they picked up a cigarette
just imagine,
after a heart attack. Yes, exactly.
And then you become nagging, and you feel that you have no control over the patient, and you want him to eat carefully, to exercise,
to smoke,
to cease smoking, to take the medications, to go on. To go meet his physician, his or her, and you have to believe that your partner is doing the right things. But if he doesn't, then the caregiver becomes very, very annoyed and burdened.
Right, and there's a whole dynamic that develops there.
Exactly.
Well, speaking of after the event, I read that in Israel, cardiac patients are offered 3 months of rehabilitative care after the event, where they even meet with their different providers in the hospital. And yet, what I was surprised to read was how few of them take advantage of this, I wouldn't even say opportunity, of this necessary offering. How do you explain that?
This is something we delve into studying for many years because we were as astonished as you are. I mean, you have a free of charge, excellent treatment, which is life-saving, and still we are talking about 20 to 50% of patients using these services.
Makes no sense.
What's going on? So we believe there are all kinds of reasons for that, behavioral, emotional, and also systemic ones. For example, one of our studies showed that if a person, the patient, is not provided with a letter of recommendation to use rehabilitation after he completed his time in the ward, he wouldn't go there. He wouldn't take this offer. So the physicians in the cardiac care unit must recommend continuing rehabilitation for the patient. Otherwise, he wouldn't.
Because he doesn't think it's necessary?
Exactly, and he prefers not to because it's time consuming. He has to travel there. He needs to agree to look at himself as a patient and not just, forget about this.
Right, it just happened and now I'm over it.
Exactly. No,
he doesn't want to change his status into somebody.
Exactly, and
understood.
It's very difficult to accept the fact that I'm coping for the rest of my life with a chronic disease and I have to self-manage this disease in order to prevent it from re-popping and re-hitting again. And we tend to deny. We tend to deny the fact that we are in such a danger.
Right.
We don't want to think about it. It's a defense mechanism. And we need to help the patient use these programs and take advantage of whatever the system provides.
Offering, right.
Exactly, in order to prevent the illness to
recur. Exactly. I would expect as a psychologist, right, there's systemic issues, but now that you're talking about it, it seems to me it must be very, very difficult to think of one's status as changing from a healthy person, the way you started the conversation. They were healthy 1 minute, and all of a sudden the next minute they're having a near-death experience, and they can't just ignore it if they go for rehabilitation. They have to do lifestyle changes. They have to acknowledge this is something, their status as a healthy person has shifted a little bit.
Exactly. And one of our studies was shocking. We asked the person to, just look at the two circles and state how much of the illness circle covers my self circle.
Like a Venn diagram.
Exactly, a Venn diagram. And lo and behold, they say, no, not at all.
Wow.
I mean, I'm here and the illness is there. So total denial. But then again, we ask the caregivers. And you know what? they were like that. I mean, I'm pointing into two circles, totally covering each other.
They were almost 100% covered
exactly.
each other.
So the caregivers understand immediately that, yes, we have an illness here and we share it and it's here to stay. Whereas the patient, and I'm talking about 48 hours after being in the, having a cardiac event with all the pain and the suffering and the fear, no, I don't want to have this. I don't want to be part of the sick population.
Wow, I mean, that's really interesting.
So this is all about psychology and medicine.
Yes.
We have brilliant solutions. We implant hearts. We have the best cardiac medicine we can imagine. But if we don't have the motivation of the patient, and the engagement of the patient and the agreement of the patient to take the medications, to change his life habits, we won't be able to save him or her. So what's so fascinating about a lab that is focusing on psychocardiology is that it's a lab of psychology. It's the psychology part is
critical.
Absolutely,
exactly. It's necessary. It's absolutely. You need it in order to get to all the other advantages.
That's the heart of the matter.
There you go.
Because in other diseases, you have to count on, the very difficult, treatments, maybe chemotherapy or all kinds of sophisticated treatments that either work or not. But in cardiac illness, it's all about behavior.
That's fascinating. Really interesting. And there are options, there are available things, but if the patient himself doesn't change, none of it's worth anything.
We cannot help him or her. We just we can only, offer. We can only try to engage, but we have to have the patient as the number one agent.
Yeah.
In order to make him, her better.
Well, you're using the genders interchangeably. Is it the same for men and women in the role of patient, caregiver? Is there a different dynamic when gender gets involved?
That's so interesting. Usually, common people would say, layperson would say, well, cardiac illness, this is a man, this is men's disease because we only see men getting heart attacks on media and movies and so forth. But no, women catch cardiac illness just as much as men, and they die. This is the number one killer for women as much as men across the board. However, women tend to get heart attacks 10 years later than men. Like in Israel, the average age for men is 61, 62 to get your first cardiac event, but for women, it's 70. So usually when you are on your 70s, you are either a widow or you take care of an older spouse.
Wow, okay.
So for me, when I study relationship in illness, I focuses on men and their women caregiver, because this is the age when the relationship is very dominant. For women catching heart attack, usually I don't have the spouse in the game.
There are other variables that can't be held constant, like they're already taking care of somebody else.
Exactly.
So it's a different
different
dynamic.
Own issues, yes.
This one's cleaner in some ways.
In a way, yes, in a way.
You could just focus specifically on this,
on the relationship
there, without all the other complicating things.
And what we find is that the relationship matters a lot. And the relationship really changes the picture. If the relationship is good, then the spouse is more engaged, then the patient is taking care of himself better, and the depression and anxiety are lessened. So it's all about the caregiver and the relationship. And unfortunately, the health system still focuses only on the patient,
right,
on the one person who has the illness within his body, but there is a system around him, and we have to take care of the system. And this is one of the major issues we have to change. We have to look at it from a much more holistic point of view, and many times take care of the caregiver in order to better care the patient.
So interesting. I remember reading a study that men who are in relationships tend to live longer. And I never pulled it apart. I just thought, oh, it's healthy for them. But here's another example where very practically, you know, men who have cardiac events are more likely to not have a recurring event or even be able to sustain the recurring event because of a supportive spouse.
Because of the support
or partner.
A spouse or partner, you know, an engaged person who lives with you and takes care of you, and, you know, even schedule your meetings with your physician.
Make sure you take your medication, drives you to the hospital.
Cooks for you, healthy food.
And is supportive, just generally supportive, and you know someone's there loving you. And I assume that also matters in terms of how one perceives oneself. If you were, you know, you thought of yourself as a man, and your partner still makes you feel that way, in spite of the fact that the event doesn't transform that part of who you are.
Which usually the event really hurt
that
exactly
piece.
There.
Yeah, it's the ego and
the ego and the understanding of my identity
and
as
who's supporting whom and who's
the social roles within the couple. And once you have a stable relationship and a loving spouse, then your recovery will be better. Your rehabilitation will based on these assets that you bring into the coping with the illness. But once you are deprived of these very strong assets, so to speak, or resources, then your coping procedure or process will be less effective.
That's just so interesting. People don't take psychology and all of these holistic, as you said, variables into account, and it's critical.
It's all about psychology.
Is what you've learned in the space of cardiac events. I mean, I know a cardiac event, you already framed it as it's shocking, it's near death, it's traumatic, it's very different than a diagnosis that takes time to come to fruition. But can you apply some of these ideas across the board to other illnesses, other dynamics, relationships within the health space?
Yes, indeed. I'm focusing on this very traumatic kind of disease that people have to cope with. But what I see from my research and my colleagues around the world that are focusing on caregiving is that caregiving is the name of the game across the board when we are talking about illnesses altogether, especially when you caught the illness, when you catch the illness when you are a grown-up. And that if you, let's put aside, you know, children diseases, which is all about parents and child.
But it's also caregivers, they're
which
just parents.
Is also caregiving, exactly. And then you have the time of your life that many of us, not all of us, but many of us have a partner. That's the common way of living. Then it's all about the caring within the relationship of a spouse or a partner. But then when you get older, then you have your older daughter or son, your children that take care of you, and this is also caregiving.
Of course.
This is what we know as caring for a person with dementia. So our life as human being is all about caregiving. We start when our parents take care of us, then we become a caregiver or we need a caregiver, and we end up desperately
taking care of or needing both, right?
So that's our life circle, and caregiving is the word. And society, the westernized society, they don't put enough attention about the caregiving person, and caregivers all over the world are in much stress and even in worse physical condition because they take over this burden and toll of taking care of another person who is sick, ill, or deteriorating cognitively. And that's the name of the game. So yes, we have to take care of the carer.
Right, and across the board, not just in these events.
And every age.
Right, and I know that you focus on trauma as well, broadly. And if I can just sort of veer from this topic a little bit to something that I know personally from my time at Bar-Ilan that you were involved with, which was post-October 7th. You described the event as something that was going to lead to prolonged trauma in the population. So what made you think of it that way, as something very different than a different war, for example? Or maybe it's the same?
No, I don't think it's the same. I think what we have witnessed as a country, as a society in 7th October is very different. And it's different from, I can't say common trauma, but it's different in a way. It was first cataclysmic. Mm-hmm. Cataclysmic in the meaning it was so terrible, so horrific, so you can't imagine.
Incomprehensible.
It's incomprehensible. But this is the point of trauma. Trauma is incomprehensible. Whether it's a Holocaust events, whether it's a rape, whether it's an earthquake, it's something so difficult, so beyond the expected and beyond life as we know it. Mm-hmm. This is what defines trauma, to be beyond our way of understanding the world as we know it. It's something else. It's from a different world, and this is what we experience, but to a very high degree on October 7th. So it's cataclysmic, but it's also shared trauma. I mean, it wasn't one person trauma. It wasn't one community trauma. It was a country trauma. I mean, there's not one person in Israel that haven't had some kind of engagement with this kind of trauma, whether he only saw it on television and heard about it. And of course, many of us knew people who died, who suffered, who their loved ones suffered or died. It's a countrywide trauma. This is something very unique. And the third issue is that it's still going on.
Right.
It's a prolonged trauma. Our hostages are still there, suffering beyond imagination. We have a war going on, and our soldiers are still dying. We haven't recuperated from this event. We haven't even ended the event to start the recuperative process. Exactly. We cannot start rehabilitation. We are still in the midst of a very traumatic, prolonged and shared trauma. It's also shared by the medical teams and by the psychological teams. We are all under this traumatic sense, and it will take us quite much to recuperate.
But you didn't just observe. You actually got involved and started an amazing project called the Teddy Bear Resilience Center. Right. I knew it would bring a smile. Me too. It's at least, well, there's something about responding to it that, as opposed to just suffering through it, saying, I'm going to try to address this and help in some way, which you did with this project. Can you tell us a little bit about it?
Well, it wasn't only me. It's a huge group of wonderful people that all of us on October 7th, and we just had to do something, especially us that have the skills, psychologists, social workers, medical staff. So we came about together, the psychology department in Bar-Ilan University, the social work school, and our health faculty, medical faculty in the north of Israel. We all kind of grouped together, and we built upon the hospital for teddy bears that the medical faculty used to do every year for 10 years in a row, to just bring in kids with their dolls and teddy bears and treat them in order to, reduce anxiety and fear of physician and medical tests. And we built upon that, and we came up with a protocol to actually treat in a one session therapy those kids who were evacuated or suffered from the alarms and the sirens, and we brought them to the university or to other places around Israel with all the students from the social work school and the Department of Psychology and the medical faculty, and the kids came with their parents, with their dolls. We took care of the dolls both medically, but also psychologically. And we kind of taught the children how to treat the doll, but actually we taught the children how to take care of themselves when they are very anxious. And also we taught the parents how to deal with the children when they are very, very anxious. So we have a protocol of a one session, one meeting when the doll and the child and the parent were educated on how to cope when something really anxiety-provoking happens. And we heard that it was extremely helpful. So we had this bus and we traveled around Israel.
You went to the Dead Sea where there were
Yes.
evacuees. You went all over the
We went
country.
to the
You
north,
went to the north.
to Tiberias
Yeah.
to assist them, and we wish to continue since we were based on volunteering, on students volunteering. We are waiting for them to have this semester break or summer breaks to initiate it again and to help the so many kids all over Israel who suffers from ongoing anxiety and even depression and post-trauma because of what's going on and still going.
So you used the teddy bears sort of as proxies for the children.
Exactly.
Because I assume what I'm gathering is
Exactly.
that for the child to get up and talk to you about the trauma is too immediate for some of them, but they could talk about the trauma their teddy bear has,
Exactly.
and then you could show the parents how you treat the teddy bear, the child could be involved in the process, and through that everyone can learn, because it's not, the child doesn't have to express their own anxiety, but clearly whatever they put on the teddy bear is what they're thinking.
Exactly. It's a total projection. And we had a kid that I taught the students, and I asked this kid, what does this teddy bear eat? And he said, well, he doesn't eat much lately. And I said, and why is that? And he said, because he's very sad. And why is he so sad? And then it continues, and just by asking a very, very neutral question about eating habits, then it all kind of opened up, and we understood how depressed was this poor doll, and and of course this poor child.
Right.
And the parent was in awe because he had no clue that his child is, thinking
Right.
about that and feeling these down kind of or negative feelings. So we had to prepare these kits for the parents to use at home, and we did, and for the child to help the doll. But basically, when you breathe, deep breathing with your teddy bear, then you breathe, right?
Of course.
And also the parent breathe, so it helps the entire family.
The holistic treatment
The
you were talking
holistic
about.
treatment, exactly.
Right, because the child can only get better if the parents are able to help them as the caregiver. And you help the caregiver, and you empower everyone in the process.
Exactly.
And so much of the trauma was about feeling helpless, I would think.
Exactly.
So once you
Exactly.
gave them the skills and the tools, it's not that the trauma goes away. As you said, it's going to be prolonged.
But you cope.
But you learn that you can address it, and there are things to be done. And that's huge.
That you said something very important. I have no control over what's going on, unfortunately, but I can have a little bit more control about how I react to whatever happens to me. Okay, and
Right.
this tiny bit of control makes a huge difference.
Right. For all of us.
For all of us.
I think so much of the cause of anxiety is a feeling of lack of control.
Absolutely.
Right.
Absolutely.
That's just the layperson's understanding.
No, but
through self-examination. You know?
A layperson is the person who cope. And lots of it is what we learn from the patient.
Right.
And we understand, and then we kind of transform and translate it into systematic interventions. But basically, it's all about what people need.
Right, so it's very personalized. You're associated with the Dangoor Center for Personalized Medicine. It seems like everything you do is personalized, or the psychology, I suppose. Although I assume, as you said, you developed protocols. It's not, you have to have the general protocol and then you have to adjust it so that it could be broadly used. Because if everything's just this conversation, that's therapy, that's great, but it doesn't, not everybody has access to that kind of immediate.
But then again, we do believe that once you have a protocol, you have to accommodate it to the specific person, the specific family, the specific context. So you always move from the general to the contextual. And when we talk about, medicine, personalized medicine, it's also, psychology thought about it to begin with.
That's right.
We begin with taking care of the person in the clinic. But what we also want to add is it's not only the person, it's the person within a family, within a culture, within a community, within a country. So this is, we go up and down, within and outside, and this holistic view makes the treatment helpful. We have to make it to the person, to his microbiome and his heart, but also to his family and his whereabouts.
Right, and then it's bi-directional.
Exactly, and it's holistic,
and it's holistic
again.
Right. So where do you see your field in 10 years? Where would, in your vision, if you could, I don't know, push the research forward, push the application of it forward. Noa, you got the wand. Where would you go with your magic wand in 10 years?
Well, my vision is that that rehabilitation psychology will be much more integrated into the medical field. I believe that we are a little bit too separate, and that physicians are working with the body and psychologists are working with the mind, but we have to work much in better synergy and interaction, and we have to come up with adjunct or entwined protocols that take into account the person's body, but also motivation, also resources, also family, and understand that you cannot treat a person medically without taking care of his mental being. And that's the integration I would like to see in the medical field. For example, now I'm doing a really, really hot study that is really, really in my heart, so to speak, or I really like it. And we are focusing on couples in which one of them has to use a artificial heart.
Interesting.
And that's really amazing, because this thing kind of replaced the actual heart, and the person has to go with this little trolley with a battery inside, and his spouse or her spouse has to change, the remedies and plasters, and every 2 or 3 days, and this is really intrusive treatment. So you have to look at it from a couple point of view, from a dyadic point of view, and now we are starting a huge project looking at artificial heart implantation from a dyadic perspective, and even thinking of coming up with devices, with actual devices that are accommodating the relationship needs, not just the
What does that mean?
Meaning that the cable coming out of your body will be situated in a place that you can have intimate relationship, for example.
Wow.
Take that into account when you think about devices.
And I'm sure nobody considered that. They're just busy with the heart. Put it wherever it makes the most sense. Just deal with the heart.
Stay alive.
Right.
But you have to have quality.
That's right.
Not just longevity.
And the relationship, again, it's not just quality of life for you, but an integral part is your part. This
is where we are heading.
I understand why this is close to your heart.
Yes.
It's a beautiful project.
Thank you.
It really is, and so much of what you do is beautiful, Noa.
Thank you.
You are not just noting the need for things, but doing something about it. And that makes you and your team just really special and important for us. So thank you for opening all of our eyes to the breadth and the depth and the complexity and the holistic nature, I got your word, the holistic nature of medical care. And I wish you the best of luck with everything, because it makes a huge impact for all of us. So thank you.
Thank
really.
you.
This was such a pleasure.
Me too.
Always,
Thank you very much.
Always. Thank you, Noa.
Bye, Sharon.